So I usually do this as more of like a, a discussion sort of, board style, oral board style. I don't expect you guys to know all the answers. I just, we're going to talk specifically about breast cancer. I'm a surgical oncologist, but I primarily specialize in melanoma, sarcoma, and breast cancer. So I want to get you guys started with just a little bit of vocabulary, because when you're talking about cancer, there's some words that are, true for any cancers, and they're important for when you're distinguishing things like adjuvant versus neoadjuvant. So do you guys know the difference between adjuvant and neoadjuvant?
Neoadjuvant is before?
Yeah. And hopefully the police are not coming. They're not invited. So if we have neoadjuvant treatment, it's before what?
Surgery.
Right. So usually before surgery, before definitive treatment. So it doesn't have to be surgery. So there can be neoadjuvant treatment before things like lymphomas or leukemias that aren't treated with surgery. So it really means it's a treatment before definitive treatment. And your plan is therefore curative if you're doing a, quote, neoadjuvant approach. So someone who's diagnosed with a stage 4 cancer who's put on chemo and then may have surgery later, that's not a neoadjuvant approach, because their surgery might be something that's more palliative. And so in that case, that's a palliative chemotherapy. So any treatment that's given for stage 4 palliation is considered palliative, not neoadjuvant, even if they are then going to have surgery eventually. So cancers that are treated neoadjuvant include things like rectal cancer that gets a neoadjuvant radiation and chemotherapy approach, esophageal, more and more gastrics, more and more pancreatic, and breast cancers in some cases, which we'll go over. So then what is an adjuvant therapy?
After definitive treatment.
Right, so not every cancer will require an adjuvant therapy. An adjuvant therapy is intended to sort of, it's like the icing on the cake. It's something given in order to either increase the benefit of the treatment or prevent recurrence. So adjuvant treatment, again, would never be given to somebody with stage 4 disease. It would be given to somebody who is being treated with curative intent. So in melanoma with stage 3 disease, we give adjuvant immunotherapy, and that's intended to keep the cancer from coming back. So technically, an adjuvant is usually given to somebody with no evidence of disease. You've done the definitive treatment. The adjuvant is intended as to decrease the risk of recurrence. My cat is rubbing on my feet, so she gets to be in the video. She won't leave me alone. So those are terms that are important. So now the other things I like to talk about is the difference between a test that is done as a screening test versus a diagnostic test. Who knows the difference between those?
A diagnostic test, aren't you sort of like certain of what you're kind of looking for, versus like screening is kind of like a catch-all?
Right, so screening is done as for someone you don't think is affected by a disease, but you're screening them to make sure. Any colonoscopies or screening tests, prostate exams with PSA, mammograms, anything that's done intending to find something asymptomatic. So that's a screening test. Whereas a diagnostic test, the patient has a symptom and you're trying to diagnose the cause of the symptom. So that becomes important when we talk about mammograms and the different kinds of screening mammogram versus diagnostic mammogram. Okay, so let's go right into it. Let's start with, I'm going to skip over benign breast disease, things like abscesses and all of that, because it's in general, you guys probably already know that stuff. So for breast cancers, the first kind of question I like to start with is a patient who presents with a palpable mass. So basically this is, what is the workup of a palpable concern in the breast? What's the first step?
Ultrasound it?
Physical exam?
Yeah, so probably history and physical, obviously, first step for everything good. You're interested in family history, of course. You're interested in her age, her contraceptive history. Is she currently taking birth control pills? Is she currently pregnant? Is she somebody who's had 20 other things in her history of breast issues? Did she have a fibroadenoma before or something like that? So you start with history and physical. So you find out she's got no family history. She's 45. She's premenopausal. She has a 3 centimeter palpable mass in her right breast and no skin changes. It's not painful, no adenopathy, and no problems otherwise. No other systemic complaints on a review of systems. So what is your first step in the diagnostic workup? Someone said ultrasound, which I would agree with, but what else?
And she's above the age of 30, would you want to get a mammogram?
Yeah, so she's 45, so she would get a diagnostic mammogram. And actually, the ultrasound you mentioned is part of the diagnostic workup. So a screening mammogram is usually 2 views, like chest x-rays. Anything with radiology, you want 2 views, right? Because you want to see things from different angles. So a standard screening mammogram is a 2-view image where they do cranial caudal, sort of looking at the breast from top to bottom, and then MLO, which is medial lateral oblique. They call it MLO because it's medial lateral oblique, and the reason they do it oblique is to try and get the axillary tail of the breast. So it's not a perfect medial lateral, it's angled. So those 2 views are a screening mammogram. With a diagnostic mammogram, they would do those views, and then they would probably do some close-up views of this image, or of this area of concern, and an ultrasound. Okay, so, and ultimately a biopsy if it's warranted. So what are some things that a palpable mass in the breast could be, a non-painful palpable mass in the breast?
Fibroadenoma.
Probably the most common. Fibroadenomas have a distinctive appearance. On an ultrasound, they look more smooth, and they have a very homogeneous sort of appearance. They're not spiculated. Cancers tend to be spiculated or star-shaped. What else?
Maybe like an invasive ductal carcinoma?
So invasive ductal carcinoma is the most common breast cancer. That's about 90% of breast cancers are ductal, the other 10% being lobular. What else?
Could be fibrocystic changes.
Yeah, could just be an area of dense breast tissue. Could be a cyst. Could be on ultrasound that's a fluid-filled cyst. And in that case, it might be aspirated and have no problems with it. For most cysts, and this is true of anywhere in the body, if they're simple, thin-walled, without septations, without mural nodules, without evidence of anything other than a simple cyst, they're generally benign. So for breast cysts, if they're small, they're left alone. If they're large, they're aspirated. And if the aspirate is clear, it's usually discarded and nothing else is done. And if the cyst fully resorbs, so on imaging, they aspirate it and nothing's there afterwards. Now, if they aspirate it and it comes out bloody, they'll send it for cytology. And if they aspirate it and then there is a mass resulting, and so it may have been like a cystic and solid thing, then they would biopsy the solid component. Okay, so fibrocystic stuff, benign stuff, fibroadenoma, cancers, cysts. There is a kind of fibroadenoma that's malignant called a phylloides tumor. I wouldn't expect you guys to get asked about that much. They're very uncommon. I probably see 1 a year. Those grow rapidly and they start as a fibroadenoma and they sort of malignantly degenerate. They don't metastasize, they act more like a sarcoma. Okay, and then of course you have to, there's all these zebra things that can occur in the breast, like there is a kind of, sarcoma of the breast. There's a kind, people get all sorts of weird things, Castleman's disease, don't worry about those things. So ductal cancer, if this woman has a biopsy and it comes back invasive ductal carcinoma, the tumor itself measures 3 centimeters. She gets sent back to you with her pathology report and it says it is a grade 2 invasive ductal carcinoma, and what 2 receptors and 1 protein are we going to look at to help determine her treatment?
ER, PR, and then HER2?
Correct. Good. So estrogen receptors are normally found on breast ducts. So with cancer in general, the more aggressive cancers become more de-differentiated. So if a cancer looks like the tissue it originated from, it's less aggressive. And as they mutate, becoming more and more aggressive, they kind of forget where they started. And so a normal breast cell should have an estrogen receptor and a progesterone receptor. Those are things they have. If they lose them, that means it's a little more aggressive. In the world of cancer, the more aggressive things tend to respond better to chemo and radiation. But obviously in breast cancer, would you rather her have an estrogen receptor or her not to have an estrogen receptor?
Estrogen receptor.
Yeah, have it. So obviously it is much easier to treat, less aggressive, and better prognosis with the estrogen and progesterone receptors. Those are things that are mostly there. Most breast cancers do have them. And then the HER2. So what is HER2? Anybody know what it stands for? It's HER because it's breast cancer, right?
Human epidermal growth factor receptor 2.
Nice. Very good. Is it present only in breast cancers? She asks knowingly. No. Can you think of any other cancers that can have HER2 expression?
Ovarian?
I don't
Is that
know.
estrogen?
Not that I know of. Think GI. It can be esophagus and gastric cancers can have HER2. HER2 overexpression is found with those. It was first described in breast, and it is one of the first targeted proteins in cancer. This cat, I swear, get out of here, kitty. So weird. HER2 is a protein that shouldn't be there, unlike estrogen receptors. So what we say is ER positive, PR positive, meaning the receptors are there, but with HER2, it's an expression. It's an overexpression or a normal expression. So they actually look at they look at a protein that is constitutively expressed in a cell called CEP17, and they label it with fluorescence in situ hybridization, and then they label the HER2 protein, and they compare the ratio of the two. If the ratio is 1, that's a normal amount. If the ratio goes above 2, that's where they start saying it's overexpressed. So they are HER2 amplified or HER2 overexpressed. They aren't HER2 positive. So again, just details. People get all anal about details, you know. But HER2 overexpression, is it a good thing or a bad thing? Bad. It's very bad. It's a marker of a high risk type of breast cancer, very aggressive, and only about 10% of patients have it. So now this patient will give her an ER positive, PR positive, HER2 non-amplified or non-overexpressed cancer. So that's the most common type of breast cancer, grade 2, most common grade. She's a healthy 45-year-old woman. She has a 3-centimeter mass on physical examination. It's fully mobile. It's not eroding through the skin. It's not eroding into the chest wall. It is easily movable. What do you have as her treatment options? What would be your first step in treatment? She doesn't have any evidence of metastatic disease, and we don't stage these patients when they have stage 1 or 2 disease, which, you know, technically with breast cancer, you don't know the stage yet, but when you examined her lymph nodes, they felt normal. When they did an ultrasound of her lymph nodes, they looked normal. So what would you recommend for that patient?
Lumpectomy.
Yeah, lumpectomy. What's the medical term for lumpectomy? That's kind of the colloquial. We call it partial mastectomy. So partial mastectomy meaning just removing the partial part of the breast, or we also refer to that as breast conservation therapy. So lumpectomy, breast conservation, is that better or worse than a mastectomy? Patient says, but doctor, why don't you just take the whole thing? I don't ever want this to come back. I want it gone. Just take my whole breast. What would you tell her? Is it better to take the whole breast or just take the lump? Is she going to live longer if she takes her whole breast off?
I don't think it has, mastectomy has a survivorship benefit, but it's kind of like up to the patient, like what they feel comfortable with. Like if they want a mastectomy, can't you just give it to them?
Right. So that study was done in the 80s. They looked at, because back in the day, every woman with breast cancer got a mastectomy, and she actually had all of her lymph nodes removed too. And that was an operation developed by Halsted, one of the most famous surgeons, who also developed the residency program in any residency. So Halsted developed the modified or the radical mastectomy. They took the whole breast, all the skin, the pectoralis major muscle, and all the axillary lymph nodes. That was a radical mastectomy, operation very rarely done. Then they dialed it back to modified radical mastectomy, which is the whole breast, all the lymph nodes, but not the muscle. And then in the 80s, finally people started saying, do we really need to do this horrible surgery on these women? What if we just take the lump? Well, if you just take the lump, there is a risk of recurrence that can be high, even with negative margins. So what do we do to combat that risk of in-breast recurrence?
Can we do some radiation therapy?
Yeah, exactly. So we do radiation, and we reduce the risk of in-breast recurrence by about 60%. It's about a 2/3 reduction. And we think that why that, this is a ductal process, the ducts go everywhere. And the way I explain it to my patients is maybe one of those little cancer cells kind of wandered off down a duct. And even when I remove the lump with negative margins, one of those little cancer cells might have wandered off and it can grow back. If the whole breast is gone, the wanderers are gone. So if you remove the whole breast, you don't need radiation. So the way you have to think about it is partial mastectomy, lumpectomy, is only okay with radiation. Those two have to be done together. So in the 80s, that study was done. They looked at lumpectomy with radiation versus mastectomy without radiation. And you're exactly right, Ashley, the survival was the same. There is no benefit to removing the breast. What a lot of women think is by removing the breast, they may remove their need for chemotherapy. And in fact, that's not the case. The chemotherapy question is not answered by what type of surgery they have. It's answered by what type of tumor they have and how involved the lymph nodes are and things like that. Size of the tumor, lymph nodes, basically staging. But what you also said is true. If the patient says, I want to have my breast removed, I honestly don't fight them on it. Some people do, as long as it's an informed decision, meaning it is not going to make you live longer. Your cancer can still come back. You may still need chemo. It's a heck of a lot more surgery. It's disfiguring, even with reconstruction. It will involve drain tubes, a stay in the hospital. That's a large operation. It's not something to be taken lightly. If after all of that consideration, the patient still says, you know what, I'm just not going to sleep at night, I want it gone, as long as they're aware of the implications, then I'd do what they want. Now, if they're elderly, incapacitated, Plavix, pacemaker, any of those things, obviously less is more. You want to get their cancer treated with an operation that will not, hurt them. So a lumpectomy, even with a lymph node procedure, is an outpatient procedure, takes us about an hour, hour and a half, and they go home the same day without a drain. It's an easy operation to recover from. Mastectomy is a lot harder, especially with reconstruction, which we'll talk a little bit more about. Okay, so you're going to offer her the two options. Hopefully she's going to say, yes, I would like to have a lumpectomy. And then what are you going to do to stage her lymph nodes?
Could you do like a sentinel lymph node biopsy and see how far the cancer might have traveled?
Yeah, what's the sentinel lymph node biopsy? Do you know how it's done, or have you seen it done?
I haven't seen it done, but I think I remember it was the first few lymph nodes are taken just to see if it's made it to a certain point. If it hasn't, then it hasn't traveled any farther, and that's how you can kind of gauge the staging.
Mm-hmm, right. So the lymph system has, they're connected in parallel and in series. You have 30 or 40 lymph nodes in each axilla. And the way the procedure is done is by removing the first one in line. So I describe it to patients as they're almost like a string of pearls or a row of Christmas lights. And you have the little lymphatic channels that lead from the breast up towards the axilla. And then the first lymph node it hits is number one, is the sentinel node. And then there's another one and another one behind that, so on and so forth. So they're all connected together like a string of pearls. But they're filters. So if a cancer cell is spreading through that lymph channel, it's going to stick in the first lymph node it encounters. So how do you figure out, they're all in a big clump like grapes under your arm. How do you figure out which one is sentinel?
I believe it's, they have a radioactive tracer. There's also a blue dye.
Yep, right, exactly. We use both. So this procedure, the sentinel lymph node biopsy, is used not just for breast cancer. We use it for melanoma. Other soft tissue sarcomas occasionally use it, sometimes even squamous cell carcinomas of the skin. Some GYN cancers and GU cancers use it. The dye is injected, and it is a dual tracer. So the first is a radioactive tracer, and the second is the blue dye, as you mentioned. This procedure was developed in the 90s, early 90s, and by a surgeon named Don Morton in California. And he developed it in cats, fitting with, my cat is still bugging me. By injecting a dye, he was able to find, that the dye would get into the lymph and then stick in that first lymph node that it encountered because of the filtration property of the lymph nodes. They learned that by using dual tracers, both radioactive and blue dye, the sensitivity of that test goes up. Specificity was already very good, but the sensitivity, you get it as high as 95%, which means the false negative rate is 5%, okay? Which means you're not always going to catch it. There are going to be patients where you do a sentinel node procedure and you didn't get the right node. And so it's in the hands of a surgeon that's been doing it for a long time, it's probably closer to 98% sensitive, but it does happen that this cancer can skip the lymph nodes. Breast cancer is generally lymphatic spread. It doesn't usually hematogenously spread initially. And so for most cases, if it's not in the lymph nodes, it's not anywhere else. Doesn't mean it can't recur elsewhere, but certainly that's the first place that it goes, is those lymph nodes. Okay, so the technetium, this radioactive portion of it, it's like a radioactive labeled sulfur particle. And because it's particulate, it's a colloid, it will better stick in those lymph nodes. And so we inject it into the breast. Studies were first done injecting it peritumorally or periareolar, however you say that. And it doesn't really matter where you inject it. You just inject it in the center of the breast and it finds its way to the sentinel node. So it's you kind of think to yourself, well, shouldn't you inject it right by the tumor? But actually it doesn't. They did that study. It doesn't make a difference. You inject it right around the areola of the nipple. And then we use a little gamma probe, basically like a Geiger counter that we point at the lymph nodes, and when the thing beeps at you, that's the lymph node that's radioactive because it picked up that radioactive tracer dye. Okay, so for us, we do that in the operating room, and we make a second incision under the arm, and we try and get about 3 lymph nodes out. One of the reasons is it's just a better sampling. You don't want to take 10, you don't want to take 1. 3 is a good number. If you tell a patient 3 out of 3 your lymph nodes are negative, that's very good. If you tell a patient 1 out of 3 or 1 out of 1 is negative, it's kind of like, not as good. Most people do have 3 sentinel nodes, and that's a good number to have. Why don't we want to take all the lymph nodes out like we used to?
Risk of lymphedema.
Exactly. So lymphedema is swelling of the arm, doesn't go away, can last your whole life, can be improved with physical therapy and some manipulation they do like a compression garments, but generally it's a lifelong process. And it occurs in 30 to 40% of people who have all the lymph nodes removed from under their arm. We say all, but really for breast cancer, it's levels 1 and 2. For melanoma, we do 1, 2, and 3. You guys, the anatomy of the armpit, remember level 1 is sort of medial to the pec minor, level 2 is under pec minor, and level 3 is lateral to pec minor above it. So, or medial to it. Way up high by your thoracic inlet is level 3. So in any case, the lymphedema risk is lower when you only do sentinel lymph node biopsy. It's around 3%, not 0. Okay, so this patient, you tell her, I'm going to do this lumpectomy, I'm going to do a sentinel node procedure. She says, great. You do the operation, you get the final pathology report. She's got a 3-centimeter tumor, negative margins. She has 3 negative sentinel nodes. She's going to get radiation, of course, because lumpectomy, radiation, they go together. What else are you going to consider for her as an adjuvant therapy? She has 2 potential adjuvant therapies, 3 if you count radiation. She's ER positive.
Maybe like hormonal therapy, like
Right.
tamoxifen or
Endocrine.
Raloxifene. Yeah.
Raloxifene. Tamoxifen is the first one that was developed, and tamoxifen is the SERM, selective estrogen receptor modulator. It binds to the estrogen receptor and blocks the binding of estrogen. So that is used in women who have a lot of estrogen, right, or premenopausal women. So this woman, she would be tamoxifen because I did say she was premenopausal. Then after they go through menopause, the only way women have estrogen after menopause and the way men have estrogen is through what enzyme?
Aromatase.
Yay, you remember step 1, see? Wasn't that long ago for you guys. So aromatase creates estrogen, and if you shut down aromatase with an aromatase inhibitor, they shut down estrogen production completely. So for women who are postmenopausal or have had their ovaries removed, they go on an aromatase inhibitor. Now, the goal of all of that is to prevent what? They said it's an adjuvant. It's for people who have no evidence of disease to prevent what?
Recurrence.
Yeah, but where? Is it in the breast or anywhere?
Is it in the ovaries?
No, I mean, it could be, it's to prevent recurrence anywhere.
Oh, anywhere. Okay.
I always remind my patients the surgery and the radiation only treat the breast, but breast cancer can come back anywhere. Lungs, liver, bones, brain, anywhere. The pill goes everywhere. And since this is a hormonally driven cancer in this patient, in most patients, if you take away that hormone, you take away the fertilizer, you take away the growth factor. And so the reduction in risk is by 50% for recurrence anywhere in the body. So if women kind of hedge and don't want to take the pill, there's people who hate pills, there's people who have side effects. I just remind them that your chance of your cancer coming back is doubled if you don't take the pill. And that generally is 1 pill a day for 5 years. What are some of the side effects of tamoxifen? You remember? Pharmacology class. Oh my gosh, she's making us think about pharmacology.
Doesn't
It's
it
like
cause osteoporosis and stuff?
Osteoporosis is the other one. That's the aromatase inhibitor. Because now you're talking about, little ladies with brittle bones, and you're taking away the estrogen, which is one important thing for bone health. So yes, aromatase inhibitors can cause osteoporosis. They have to have bone density tests and be treated if necessary. What about tamoxifen? I heard someone say it.
I think they're hot flashes or like
Yeah,
vaginal
both of them.
dryness.
Yep, both of them cause hot flashes. More the aromatase inhibitors than the tamoxifen. But tamoxifen has some special side effects. It's different. Remember, it works differently. It's a SERM.
Is it endometrial cancer?
Yes, there you go. And blood clots. Endometrial cancer, very rare, but it does happen. You need to make sure those women are having an annual gynecologic exam, and if they have to, any abnormal bleeding, they need to, be aware. And then blood clots. In the same way that birth control pills can cause blood clots, so can tamoxifen. That is not true of the aromatase inhibitors. It causes hot flashes, joint pain. They get some weird joint pains for some reason. Some so severe that they have to stop it. I had one little old lady, she couldn't brush her hair because she couldn't get her arm, her shoulders hurt so bad she couldn't get her arm up high enough to brush her hair. So the goal is to take estrogen modulatory therapy or endocrine therapy for 5 years. There are new studies showing benefit for 7 or 10 years. So in younger women who are doing well, who aren't having a lot of side effects, some of them are now taking their endocrine therapy longer. But still the answer is 5 years tamoxifen. Okay, so she's definitely having radiation. She's definitely having endocrine therapy, but we haven't answered the question of chemo. Does she need chemotherapy, and how can you tell? Have you heard of any tests that might give us a better idea? It used to be, not very long ago, that women who had a tumor bigger than a centimeter got chemo, basically regardless of anything else. Fortunately, that has been improved, and there's something called Oncotype testing, Oncotype DX, genetic profiling. Have you ever heard of any of that? All right, so basically it boils down to a proprietary test that was developed in a lab where they looked at thousands of women with breast cancer, and they looked at 21 genes inside the cancer cells and whether they're turned on or turned off. And so they created these patterns, and then they classified all these thousands of tumors into groups. And they know how those women did. They followed those women for like a decade. And so then when you give them a new tumor, they do the same thing. They look at the 21 genes, the pattern of on and off, and they see what group they look like. And so they'll give you a score that spits out a number, and it says, your patient looks exactly like this group of women over here. Their cancers never came back. She's low risk, and they're fine. And honestly, it is so predictive. It's been validated by numerous studies, this Oncotype score, that it is the most important test for determining who needs chemo. Now, if she came out with 3 lymph nodes positive, a lot of different things, you wouldn't need the Oncotype test. You would know she needed chemo. But the Oncotype test, or it would probably be called gene expression profiling or tumor gene expression profiling. Those are the ways that they would describe it on a test. Because there's other things that, there's other name brands. There's another one called Mammoprint that does a similar thing. There's one that they're trying to develop for melanoma that's not really caught on. So expect more of this in the future, this gene expression profiling, because it can really tell how dangerous is this patient's cancer, and it gives you an actual percentage. It'll say your patient has a 40% lifetime risk of her cancer coming back without chemo, and with chemo, it's 10%. I mean, it gives you very specific numbers, which is really helpful. Oops, I went away. I made it go away, and I don't know how. Oh, there it is. Okay, sorry, my computer did something weird. So if it's low risk or intermediate risk, based on the genetic profiling, you would say no chemo. If she's in the high risk group, you would give her chemo. And at this point, it's an adjuvant, again, given to prevent recurrence. All right, so that's the sort of run-of-the-mill breast cancer, very common treatment for most women. At least in our group, about 70% of women will have breast conservation and not a mastectomy. Next case, we're going to do a little different. So this patient comes in with a screening mammogram. She was just going in for her annual, and they found calcifications, new calcifications. And they do the biopsy, and it comes back as ductal carcinoma in situ, and she shows up in your office. No mass, no physical exam findings, never had a family history or breast biopsy. She's 50 years old, asymptomatic. What do you do for her? What is ductal carcinoma in situ?
Like a pre-cancer?
It is actually not. It's sort of a misnomer. In situ in any cancer means what? Do you know what in situ means technically?
I think it means that it hasn't like penetrated through the basement membrane.
Exactly, exactly. Regardless of whatever kind of cancer, there's an in situ stage for most cancers. You don't always catch the in situ phase, but in breast cancer, what it means is the cancer cells are still inside the duct. They haven't gone through the basement membrane. They haven't invaded. They're non-invasive. So any in situ cancer is considered non-invasive. It's not precancerous. It's still a cancer. It's pre-invasive. So it's stage 0. Now for ductal carcinoma in situ, we treat it as a breast cancer. It is treated very similar to what I just went through. They get a lumpectomy, they get radiation, they get tamoxifen, they get endocrine therapy, they get all 3. So it is a breast cancer, even though it is stage 0. The goal of removing it is to prevent it from coming back, because when ductal carcinoma comes back, in situ comes back, about half of the women it comes back as invasive cancer. And so you're preventing that. So you need to excise it to negative margins, actually wide margins. Usually we want 2 millimeters of margin around the whole tumor. And then they get radiation and they get endocrine therapy. Do they ever get chemotherapy? Chemotherapy is meant to prevent distant metastasis. So the people who get chemotherapy are the people at high risk for distant, life-threatening metastatic disease. So by definition, in situ breast cancer can't metastasize. So you do not give them chemo. You do give them endocrine therapy. Do you do a sentinel lymph node biopsy when you do her lumpectomy?
If it hasn't invaded, then no.
Exactly right. So there's no reason to, because it can't get to the sentinel nodes. It's stuck inside the ducts. However, there's always a however. You have to remember, we're basing this diagnosis on a needle biopsy that was done by radiology, and it doesn't remove the whole area. So you may have a woman with 4 or 5 centimeters of calcification seen on her imaging, and usually ductal carcinoma in situ presents as calcifications on a mammogram. They don't usually have a mass. They can have a mass, but not usually. And the calcifications are because the ducts are irritated. They get irritated from the cancer cells growing in there, and your body wants to put calcium wherever it gets irritated. So if they have 4 centimeters of calcifications, imagine in needles just taking a sample of that. Even if it's 7 millimeters of calcifications, you're never going to get the whole thing with a needle. When you go do the surgery, you are going to get the whole thing because you have to. That's the goal. Sometimes you find out there was an invasion in that area, in that broader span of disease. There was an area of microinvasion. When the pathologist gives you back your report, you may look at it and say, oh crap, there was a 2 millimeter tumor in there that was just really too small to show up on imaging. or a microinvasive, even smaller tumor. Now, what are you going to do? Now you found out in retrospect she did have invasive disease. What do you do? You just take her back for a sentinel node. So if she's healthy enough to have sentinel node surgery, she's not an 85-year-old lady in a wheelchair with oxygen, you would go back and do the sentinel node. So this is where preparing patients for surgery becomes very important. You have to tell them honestly, there is a potential for invasive disease to be found on final pathology. It occurs in 10 to 15% of women, which is pretty high actually. And so you say, just so you know, there's a chance we may find invasive disease and we may then have to go back and do a sentinel node. So that brings me to my next question. How did I tell you guys we find the sentinel nodes? Where do we inject that dye?
Into the breast. Middle.
Yeah, around the nipple, around the areola. What happens if you have a 50-year-old woman who has 11 centimeters or 14 centimeters of DCIS, which happens? They have their whole breast basically is DCIS. You cannot do a lumpectomy. You have to do a mastectomy. What would you do anything different? This is one of those exception to the rule questions. So we said you never do a sentinel node biopsy for DCIS because it's not invasive. However, 10% of the time to 15%, you find out in retrospect it was invasive. So if you've already removed her breast, you can't go back and do the sentinel node procedure because where are you going to inject the dye? She has nothing to inject. So the exception to the DCIS rule with sentinel nodes is if she's having a mastectomy for DCIS, then do a sentinel node biopsy because you lose the opportunity to do it in the future. And if you get bitten, and you're in that 10 to 15% group, you want to have that information because the lymph node status is the most important prognostic status. So it determines whether she's going to need chemo, it determines her risk of recurrence and things like that, in addition to oncotype testing. Okay, so that's DCIS. DCIS is breast cancer. There is something called LCIS, lobular carcinoma in situ. It is not breast cancer. It is a misnomer. They're trying to get it out of the, they're trying to get it away from pathologists' mouths. It is an entity. It causes you to be at high risk for developing breast cancer. We do not treat it as a breast cancer. We remove it, but we don't have to have negative margins. You don't have to have radiation. You don't have to go on tamoxifen. It is just a marker for risk, not a cancer. So just DCIS. Okay, so let's do a case of a more aggressive type of breast cancer. So a woman comes in, she has a palpable mass, she's had all of her imaging, she has a 4 centimeter palpable mass in the right breast, it's mobile, no lymph nodes look fine. Her biopsy is done and it shows the ER and the PR negative and the HER2 is also negative. So we call that triple negative, HER2 non-amplified. And she is otherwise healthy. And she has a sister who had breast cancer at 35 and she's 40. So anything different to start?
Maybe BRCA testing?
Right, so definitely she needs genetic testing. So anyone diagnosed with breast cancer under 45 gets genetic testing, regardless of what type of breast cancer. Anyone diagnosed with triple negative breast cancer under 60 gets genetic testing because the triple negatives are more likely to have a BRCA1 mutation. And anyone who has 2 first-degree relatives with breast or ovarian cancer should be genetically tested. So we don't count like cousins or Aunt Sally or, my second cousin twice removed, but sisters, mothers, grandparents, siblings, and their own children. Sometimes it's even their own children that have been diagnosed. So genetic testing should be done prior to surgery. One of the reasons is it might change their treatment. So instead of a lumpectomy, they may want to have their breast removed because women with a BRCA mutation are very high risk for developing a second breast cancer in their lifetime. It's about a 50% risk of a second breast cancer. So those women most of the time say, yeah, I'm done with these, let's get rid of them, and rightfully so. So we try and get that genetic testing expedited and done soon. So if this patient comes back, even though she and her sister both had breast cancer young, turns out she's negative. She doesn't have a BRCA mutation. Can you think of any other mutations that cause breast cancer? others than BRCA1 and 2? It is associated with Lynch syndrome, so the mismatch repair, DNA mismatch repair genes. It can be associated with the P53 mutation, so Li-Fraumeni. There's one called ATM, and there's one called CHEK2, and there's one called PALB-B2. Those are a little more esoteric. I don't think they'd ask you about those, but the ones I would be very aware of are the BRCA mutations, P53 and Lynch. What else does P53 or Li-Fraumeni cause? It has a bunch of cancers that it can cause, but there's one that it's really known for.
Is it retinoblastoma?
They get young, soft tissue sarcomas at a young age. So most Li-Fraumenis are diagnosed as a sarcoma in a young person. But they do get a lot of breast cancer, Li-Fraumeni, and colon. So, okay, so she's negative, her testing's negative, her sister's testing's negative, but she is left now with a triple negative breast cancer, T2 lesion, big palpable mass. You would stage this person, I would stage this person. I don't know that your test would ask you that, but I would do systemic staging because it is a higher risk tumor type. And then I would talk to her about what would you offer? Well, let's make it a little more clear because your test probably won't give you vague questions. Let's make her tumor 6 centimeters. It's a big one. It's a T3. T staging for breast cancer, less than 2 centimeters is a 1, 2 to 5 centimeters is a 2, greater than 5 centimeters is a 3. So the numbers you have to remember are 2 centimeters and 5 centimeters. Those are the borders. So if she's greater than 5 centimeters, she's a T3, and we consider T3 locally advanced cancer. T4 is reserved for tumors that either erode through the skin, eat into the chest wall, or inflammatory cancers, which I'll talk to you about in a little bit. So she's a T3, that's a locally advanced triple negative, 6 centimeter tumor, and she's got like a B-size breast. This is one of those tumors that you can see where she still wears her shirt and you can see the tumor still. So what are you gonna recommend for her?
Go ahead and do a mastectomy.
Sure, and that absolutely is still an acceptable answer. And I think if you look in the NCCN guidelines, they'll still say mastectomy up front. And then afterwards, you find out she's got a 6 centimeter tumor, node negative, triple negative. What are you gonna do afterwards? You're gonna put her on endocrine therapy?
No, probably give her chemotherapy.
It's not, endocrine therapy is not gonna work. Yeah, you'd give her chemotherapy. Okay, so if you're gonna give her chemotherapy no matter what after, would it benefit her to give it up front? What potential benefits would she have if she did the chemotherapy neoadjuvant? Can you think of
I
any?
guess it's protective just in case that if it's already spread to other organs in her body, can start getting a start on that.
Yep, exactly. So you may have micrometastatic disease that does not show up on imaging, and the chemotherapy will treat the micrometastatic disease. That is definitely one of the purported benefits. They've been trying for years to get a survival benefit out of neoadjuvant chemo, and there's been a lot of studies that have trended towards a survival benefit, and that's the reason why, is that treating that micrometastatic disease before it becomes metastatic disease, but no one's ever given a real definitive survival benefit. What is the other thing that might happen if you give her chemotherapy up front? What could happen to the tumor?
It can shrink.
Right. So it may go away altogether. And like I said at the very beginning, the more aggressive the cancer, the more response to chemo. So if it goes away altogether, some of these women, after 2 or 3 cycles of chemo, you can no longer feel the mass. It's extremely impressive. These big, huge tumors, they just, like an ice cube in the sun, they shrivel up. And so you may take someone who needed a mastectomy and convert her to a breast conservation candidate, which is really important because most women would rather not have to have a mastectomy if they can avoid it. So that's benefit number 2. So treating micrometastatic disease, definitely. Making someone who is not a candidate for lumpectomy into a candidate for breast conservation, that's a very strong benefit. And then the third thing is the lymph nodes, and it's similar to what you mentioned with microscopic disease, is it will downstage the lymph nodes. We haven't really talked about lymph node dissection, but for cancers that have metastasized into the lymph nodes, breast cancers, the treatment is still lymph node dissection, unless lymph node dissection, meaning taking all the level 1 and 2 lymph nodes. The exception to that rule is if you treat them up front, so I'm sort of in a different scenario, but if you know the patient's lymph nodes are involved, she has a positive biopsy proven lymph node metastasis, and you give her neoadjuvant chemotherapy, and the lymph node responds, and it looks really tiny after treatment, then you can do a sentinel node biopsy on her instead of a dissection. So that's another benefit of neoadjuvant treatment, is potentially removing the need for axillary surgery and therefore the risk of lymphedema. Okay, so any patient with a locally advanced tumor, so that's greater than T3, is a candidate for neoadjuvant. Also, any patient with a T4, so T3 or T4, neoadjuvant, slam dunk. That's always the right answer. Lymph node positive, also the right answer to do neoadjuvant. If they have triple negative disease, they respond really well. And for us and for most places, even a T2 triple negative or even some T1s, we'll go ahead and give them neoadjuvant for all the same reasons. If it's a palpable triple negative tumor and they're healthy, they at least deserve a discussion of neoadjuvant treatment. Now, if it's like a 1 centimeter tiny little thing, you can barely feel it or not feel it at all, even if it's triple negative, then upfront surgery is the right answer. The reason being is what I mentioned before. If the same chemotherapy regimen is going to be recommended, whether or not they have surgery first or chemo first, then it's a no-brainer, right? You're still going to get the same chemo after than you are before. However, there are some people where the results of their surgical pathology might change the chemotherapy regimen, and that's where those small tumors kind of fall in there. So for patients who have a smaller triple negative tumor, doing their surgery up front may limit the amount of chemotherapy they need after. Now, if it's a big 4, 5, 6 centimeter, big tumor, they're going to still get the full course of chemotherapy up front that they would get after, and that's 16 cycles of chemotherapy. It takes about 6 months. But we won't go into that. It's a big regimen, and they have a lot of, they actually tolerate it pretty well, but they have a lot of treatment. So, okay, so this woman, we give her neoadjuvant chemo, we stage her staging is negative, she gets re-imaged after the completion of the chemotherapy, we repeat the mammogram, we find nothing. Looks like it's totally gone, there's no cancer left. And she says, well, if they can't even see it and I can't feel it, do I have to have surgery? What do you have to tell her? Yes, you still have to have surgery. So the only way to know for sure, right, as of right now, is to still do the surgery. But there is a clinical trial right now that we're participants in where they're not randomizing patients, they're biopsying patients, and then if their biopsies come back negative, they don't have surgery on their breast. So that study is open. It's through MD Anderson, and we're participating in it. If I were a patient, I wouldn't be in it because they have to have like 10 or 12 14 gauge cores. It's a horrible thing. But anyway, I'd rather just be asleep and have the surgery if you ask me. But in the future, there might be a certain cohort of patients who have neoadjuvant therapy up front and then don't need to have surgery. And for some reason, surgeons are really good at doing clinical trials that put us out of business. So every time we do a clinical trial, we prove that people don't need, that other things are helping people just as much as surgery. So we, as an example, the MSLT2 trial in melanoma proved that lymph node dissection did no benefit. So now we don't dissect melanoma lymph nodes anymore. So it's better for the patients. It just, it's better for their morbidity. Long-term morbidity with lymph node dissection is miserable. All right, so we haven't talked about a HER2 amplified cancer. How are HER2 amplified cancers treated differently? Do you guys know any targeted therapies for breast cancer?
Isn't there it's like a Zumab drug or something? I'm not sure the name.
Yeah, trastuzumab. Trastuzumab is one of the first Zumabs of the category. It's been around. It may be the first. I'm not even sure. But as far as targeted therapies for cancer, it's one of the oldest. And a targeted therapy is not chemo. So chemotherapy, as you guys know, is toxic to cells that are dividing, and they all work in different ways, all the different chemotherapy drugs, but they're basically just poisoning cells that are trying to grow. A targeted therapy is targeting a specific, usually a cell surface protein or receptor, and blocking it, which prevents the cell from growing. So that HER2 molecule is a growth factor. It's a growth factor receptor. And if it's blocked by trastuzumab, then the human epidermal growth factor, blah, blah, whatever the ligand is for that receptor can't bind. And those are really the driving factors for growth. In a HER2 amplified cancer, the HER2 molecule, when you shut that down, 80% of those cancers shrivel away to nothing. They really go completely away. They have, I mentioned at the beginning, it is not a good cancer to have. They're aggressive. HER2 cancers are aggressive. But because of trastuzumab, because of Herceptin, which is the trade name, the survival of these cancers is dramatically improved. And in addition to Herceptin, there's now, or trastuzumab, there's now pertuzumab or Perjeta. Perjeta is a second HER2 binding targeted therapy. It binds a different portion of the protein. So when you combine the two together, they bind even better and they shut it down even more. So now patients with HER2 amplified cancers get a combination of chemotherapy and targeted therapy. They work in a symbiotic way. And so they get a 4-drug cocktail, which is 2 drugs of chemo, 2 drugs of targeted therapy, and they usually get that for 6 cycles prior to surgery or 6 cycles after. So it's the same 6 cycles. It's given every 3 weeks, 4-drug combo. It's called TCHP. So it's the standard of care for HER2 amplified cancers. So very similar to what I mentioned with triple negatives. If you're going to give them the same chemo after, then you would give them up front. Why not give it up front for those benefits? Shrink the tumor size, kill the cancer in the lymph nodes, micrometastatic disease. The other kind of benefit I tell to patients is surgery is hard on the body and it's a stressor, causes your cortisol levels to go up. It affects your immune system. And so if you hit the ground running and you start with chemo, you're kind of at your best level for these patients. If they've just had surgery and then a few weeks later you start them on chemo, the stress of the surgery may allow that micrometastatic disease to sort of flourish. And it takes away some of your immune function because your body's worried about healing. And so those are the sort of benefits that we think to neoadjuvant. So any HER2 amplified cancer that's basically large enough to feel, we would usually put on neoadjuvant treatment. Now, what is the dreaded complication of trastuzumab? Do you guys remember from pharmacology?
I think they cause pretty bad cardiotoxicity.
Yes, it can. It's not common, but it can be irreversible. So trastuzumab is cardiotoxic. They have to have an echo, they have to be watched. And they actually get trastuzumab for a full year. So they get that 6 cycles of combination therapy, then they have surgery, and then they continue getting the trastuzumab every 3 weeks for the rest of the year. And they have to have echocardiograms while they're doing it because it is very cardiotoxic in rare cases. I had a woman who her EF dropped from normal to 15% after 2 doses. And she got better, but it was like 15% for a while. She was in the hospital in cardiogenic shock. So it is real. But it works, and those patients respond really well to treatment. All right, we have about 5 minutes left, and then and I want to get in the last topic, which is a special kind of rare cancer, inflammatory breast cancer. You've heard about it because it loves to show up on tests. And the reason it's treated differently is it has a horrible prognosis. So patients present with, and first and foremost, inflammatory breast cancer is a clinical diagnosis, which means you can't make the diagnosis on a mammogram or a CAT scan. It has to be made by physical exam, and it involves basically erythema of the breast, redness, and skin thickening, and that peau d'orange you guys have heard of, right? Where the skin looks like an orange. Why do those patients, and we call it inflammatory because it's red. It looks like inflammation, but it is not. There is no inflammatory infiltrate. It is not an inflammatory condition. Why do they get the red, thickened skin of the breast? What's causing it? What about the breast cancer is causing it? How does fluid move around in your body other than in blood vessels?
Is there a blockage of like the lymph drainage?
Yes,
That
exactly.
causes it to back up?
Specifically dermal lymphatics. So it's dermal lymphatic invasion by cancer. So the breast cancer cells invade the dermal lymphatics and they cannot drain. And so all that backed up fluid causes the skin to thicken, the peau d'orange, and the erythema, because the blood kind of backs up too. It has to be at least 30% of the breast, and usually those patients present after being treated for mastitis or some other infectious process. It is okay if they give you a question and say like, would you put her on antibiotics and then see if it goes away? That's okay, because it could be mastitis. We have to be sure that it's a reliable patient and that they're going to come back in 2 weeks and recheck. If you feel a mass, you probably shouldn't do that. But you know, in your surgery shelf exam, and you guys still take those, right? If they give you a red breast, it's inflammatory breast cancer until proven otherwise. So the treatment, it can be triple negative, it can be HER2 amplified, it can be ER/PR positive. It's usually a high-grade cancer. It's usually it's been there a while. These are usually neglected things. They don't just come out of nowhere. The breast is usually enlarged compared to the other side. Again, the edema isn't just in the skin, the edema is in the whole breast. Oftentimes they present with locally advanced, this is T4D, this is locally advanced by definition, but oftentimes they present with lymph nodes positive. They are always going to need staging studies, the first thing you would do, and they are always going to need neoadjuvant chemotherapy based on whatever their receptor pattern is. So if they're HER2 amplified, they get a Herceptin-based regimen. If they're triple negative, they get the triple negative regimen. Now, the key difference with this disease is no matter what response they have to treatment, even if they have the perfect response, complete clinical response to treatment, you can't even tell they ever had breast cancer, they always get a modified radical mastectomy. That is a hard no. You cannot do a lumpectomy. You have to do a modified radical mastectomy, take the whole breast and all of the axillary lymph nodes. And even with that treatment, and then they get radiation. So this is one of the examples of women who get radiation even after a mastectomy. So I mentioned in the beginning that if you do a mastectomy, you don't need radiation, but there are exceptions to every rule. One of the exceptions is if they had a breast cancer that was very locally advanced, even with a mastectomy, they get radiation, chest wall radiation. So those are people who have tumor greater than 5 centimeters, so T3, T4, or 4 lymph nodes positive. That used to be the old rule. Now we're doing it with even less lymph nodes positive. So just remember that mastectomy doesn't always remove the need for radiation. Lumpectomy radiation always, but mastectomy and radiation for some. So like the T3, T4s, and with a lot of nodes positive. All right, so final thing I want to talk about is Paget's disease. What is Paget's disease? Of the nipple, in this case. You guys heard of it? Yeah? All right, what is it? If you know, you win the Nobel Prize because no one knows what it is, but what does it look like?
It's just like you can see it on the skin, right?
Yeah, and it usually affects the nipple itself, but it can also extend onto the areola and even beyond. I saw a woman, it was, like 10 centimeters of Paget's disease, obviously neglected, many years neglected, but it can extend beyond the nipple, but it always starts on the nipple, and it's red, and it's itchy, and it burns, and some women will describe it as wet, like it's kind of like a rash. Their clothing will stick. It's not pleasant. So inevitably it's misdiagnosed. They get put on a fungal cream by their PCP. They get put on some kind of antibiotics, and it doesn't go away. So how do you diagnose it? Obviously they're going to get a diagnostic mammogram, but what else do they need?
Do you biopsy it?
Yeah, you do a punch biopsy. So you want to do a skin punch biopsy of the red area. You want to get the area that's red, and that's the only way to diagnose Paget's disease of the nipple. And Pagetoid cells or Paget cells have this weird appearance. You can read about it. I'm just like, it's all that stuff with the the weird nuclei. But they're weird. We don't know where they come from. There's 2 different theories. There's one theory that the breast cancer cells get up into the skin. There's another theory that some weird skin cells turn into Paget cells. the important thing to remember is that it is a breast cancer, and it always means there's an underlying breast cancer. It can be invasive or ductal carcinoma in situ. There are some women who never have an invasive cancer and get Paget's with ductal carcinoma in situ, DCIS. And so if someone comes to you, a lot of times they'll have their biopsy done by either their primary or by a dermatologist even, and their diagnosis is Paget's disease. Your job is then find the breast cancer. You have to find the underlying cause. You can't just take off the nipple. You got to figure out where the cancer is underneath. So it starts with diagnostic mammograms, sometimes MRI of the breast, which is a study that is a little more sensitive than a mammogram, especially in dense breasts or younger women. And then the treatment, you have to remove the nipple. You need negative margins on the skin as well. And you basically treat it the way you would treat any cancer. So that's just kind of the random cancers that show up. Paget's and inflammatory. Fortunately, inflammatory breast cancer doesn't show up that often because it is a deadly cancer. And then one more random, rarer type of breast cancer that I will mention, and then we'll be done, is metaplastic breast cancer. I told you at the beginning, anything that de-differentiates is bad. Anytime that a cancer becomes less and less like where it started, anywhere in the body, a de-differentiated cancer is bad. And metaplastic breast cancer is as de-differentiated as it gets, sort of like anaplastic thyroid cancer. It kills everybody who gets it. And metaplastic breast cancer, the tumor cells have mutated to the point where they start forming other tissue. So like any metaplasia, there can be cartilage, there can be bone, there can be squamous cells, there can be all sorts of things. And they don't fully understand why, but it's this metaplastic process. And the tumors look like a sarcoma. They behave like a sarcoma. They tend to metastasize hematogenously rather than through the lymphatics. Sometimes you'll actually see a ductal cancer and a metaplastic cancer together, and you don't really know which one came first, chicken or the egg. Maybe one turned into the other, but inevitably they're fatal. They don't respond well to chemo. They're all triple negative because they're not really breast cells anymore. They turn into other things. I don't think that they would ever show that on your test, but we treat it the same as we treat other cancers. We just sort of know they have the most dismal prognosis, the metaplastic cancers and the inflammatory. So I hate them when I see them. All right, so we talked about genetics. Test anybody who has a family history of a couple relatives with breast or ovarian cancer. Anyone diagnosed under 45. Males with breast cancer, men get breast cancer too. It's about less than 1%. It is treated exactly the same way. Usually men will get a mastectomy just because of the size of the breast is small, and usually it's close to the nipple when men develop breast cancer because they only really have ducts right under the nipple. So for most men who get breast cancer, we do treat with a mastectomy. Also, they still get the same radiation. They still get the same tamoxifen. We put men on tamoxifen because most male breast cancers are ER positive. Male breast cancers need genetic testing no matter what. And then we talked a little bit about what genes cause breast cancer. I don't know if they'll ask you things like screening, like when should screening start? For most women, it's 40, but they're starting to move it towards 45 without a family history. And then the other question is, when should they stop? And for the American Cancer Society, they're saying at 70, women can stop having mammograms, which I personally think is a little crazy. But with breast cancer, when it's diagnosed in later in life, it's generally less aggressive. The women who get it younger tend to do worse. So it's the opposite of other cancers. Melanoma is the exact opposite. The younger you get it, the better you do. Breast cancers in young women tend to be much more aggressive. So any questions you guys have? I know I talk a lot. My cat finally left. Now I hear my baby downstairs. So, all right. Good? All right, you'll answer all your questions right. Remember, lumpectomy, radiation. You can't go wrong with that. That's usually the answer. Sentinel node biopsy for any invasive cancer. DCIS is a cancer. You don't need a sentinel node unless you do a mastectomy because you lose the opportunity to do it later. And you guys will be fine.